through genomics. In today's session, we'll learn from experts about whole genome sequencing and how it can be translated and applied into Indonesia's healthcare context. We believe that it is through our collective effort that the precision medicine ecosystem can be built and built to last. We are thankful to RSCM and to RV for your support for today's workshop. We are looking forward to working together with you. Thank you. Terima kasih.
Thank you so much, Pak Martin, for the remarks. We here with us today, present our beloved Dr. Andalucia, Rizka Andalucia, APT M.Pharm Mars. Dr. Rizka is the Director General of the Pharmaceutical and Medical Service at the Ministry of Health. To Dr. Rizka, the floor is yours, Doc.
Thank you, and very good morning to all of the participants. My Honorable Director of Hospital Cipto Mangunkusumo, Ibu Dr. Dina, and also Pak Martin, the representative from Illumina, distinguished participants, ladies and gentlemen. It is a great pleasure to be here, and I would like to take this opportunity to extend my warmest welcome to all of you. It is a great honor for the government of Indonesia to collaborate with one of the advanced technology providers like Illumina. This year, the commemorate Indonesia Independence Day, the Ministry of Health of Republic of Indonesia has launched the first national initiative on health biotechnology aiming for the development of precision medicine in Indonesia on August 14, 2022, named Biomedical and Genome Science Initiative, or we call it BGSI. BGSI is established to lead Indonesia into the era of precision medicine by integrating genomics capacity into hospital-based health service. BGSI will start its program by collecting and sequencing 10,000 samples within the first 2 years, focusing on priority diseases in Indonesia, such as cancer, stroke, diabetes in Cipto Mangunkusumo Hospital, tuberculosis in Sulianti Saroso Hospital and also Persahabatan Hospital, rare disease or genetic disorder, and aging, wellness, and beauty that can enhance the improvement of quality of life. Ladies and gentlemen, in the beginning of COVID-19 pandemic, Indonesia only had 12 laboratories with sequencing capacity. It has become our difficulties to know the variant of the virus and also the spreading of the virus in the certain area of Indonesia. This year, with the support from Global Fund, Ministry of Health has expanded our sequencing capacity in the country with additional 24 ONTs device out of 15 sequencer in the 43 laboratories across the countries. Ministry of Health Indonesia committed to reinforce the importance of health resilience in the country. Technology like genomic sequence will play a larger role in the future healthcare system. Through genomic technology, we aim to give more accurate screening and diagnosis, and more precise treatment for our people. As Indonesian, we are all familiar with the proverb, lebih baik mencegah daripada mengobati. To prevent is better than to cure. At the President of G20 this year, we are delighted to share that during the G20 meeting, there are 6 key actions to be carried out forward. In the umbrella of the global health architecture, we want to strengthen our capability in surveillance, in the research and development, especially in the research and development in the vaccine, treatment, and therapeutic and manufacturing. So the study in genomic and in the study in the genomic for the precision medicine become the very important for the future Indonesian healthcare proposal. So, ladies and gentlemen, we want to make a collaboration between the university and the hospital and also the research center. And I think this session this morning, together with Illumina, will bring the leapfrog for our initiative in precision medicine. Ladies and gentlemen, if you want to go fast, go alone. And if you want to go far, you go together. So the collaboration is the important thing for our initiative. In the future, the Ministry of Health hopes that together we can improve our healthcare quality through multi-stakeholders collaboration and support more health innovation in Indonesia. Thank you and good morning.
Maybe a bit round of applause to Bu Rizka. Thank you so much, Dr. Rizka. Indeed, if you want to go, if you want to go far, go together. That means we're also very grateful with the presence of the Indonesia's Vertical Hospital Association networks here. We have lots of vertical hospitals joining us through both online and live streams. So without further ado, we are now proceeding with the technical part of the session. I'm inviting now, there here with us, Dr. Rina Ladistianora, PhD. Dr. Rina is a consultant at the Cipto Mangunkusumo Hospital, as well as head of the Center for Translational Research and Precision Medicine of the Cipto Mangunkusumo Hospital. Dr. Rina, please take the seat. Yeah. Yeah. Yeah, you can still at the seat. We are here with us today also Dr. Dicky Levenus, Tapahari, consultant of endocrinology, PhD at the Center for Translation and also Hub of Diabetes with the Center for Transaksional Research and Precision Medicine, CTRPM of the Cipto Mangunkusumo Hospital. Dr. Dicky is the academic staff of endocrinology at Faculty of Medicine of University of Indonesia, as well as the chairman of Metabolic, Vascular, and Aging Cluster at the Indonesian Medical Education and Research Institute, or IMERI. Dr. Dicky also serves as the chairman at the Indonesian Thyroid Association of the Jakarta branch, as well as the head of the pituitary work group of the Indonesian Society of Endocrinology. Perhaps Dr. Dicky, you want to stand and yeah, thank you. And here also with us today, our next resource person is Dr. Amol Zimur. Dr. Amol is the head of medical affairs of the Asia Pacific in Japan. So guided by Dr. Rina, Dr. Amol and Dr. Dicky will share to us, and perhaps also would like to pick our experiences on whole genome sequencing. Dr. Amol has been working in the pharmaceutical and biotechnology industry for the last 12 years, bringing breadth of experience in driving strategic medical initiatives, new therapeutic product launches, clinical studies, and partnerships with various academic and scientific institutions in many parts of the world. He also worked in a range of therapeutic areas such as oncology, immunology, rare disease, and infectious diseases. So without further ado, Dr. Rina, I'm giving the floor to you.
Thank you, Dr. Rian. Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi. Terima kasih kepada dokter-dokter yang sudah hadir pada pagi ini. I'd like to ask permission to Dr. Amol to speak in Bahasa, because this morning our aim of meeting is full understanding and the spirit to know further about genomic. Today's meeting, it's okay to use Bahasa because we want to share, mau membagikan semangat supaya kita semangat mengenai genomik ini. Dan kenapa pertemuan pagi ini diselenggarakan? Pertama, kembali kepada apa yang dikatakan Bu Rizka, collaboration is the key. Jadi kuncinya adalah kerjasama. Oleh karena itu, RSCM juga berkolaborasi dengan Illumina untuk bisa mewujudkan genomik ini. Dan kedua adalah untuk mengenalkan bahwa next gene sequencing itu bukan sesuatu yang jauh hanya untuk riset. tapi ini juga akan berguna untuk pelayanan kesehatan kepada pasien-pasien kita. Pada pagi ini ada dua pembicara. Yang pertama Dr. Amol. Pada pembicaraan Dr. Amol akan mengenalkan apa sih kegunaan next gen sequencing untuk pelayanan kesehatan. Jadi penggunaannya langsung, tidak hanya masalah riset. Jadi mudah-mudahan bisa menginspirasi dokter dan prof sekalian untuk bisa menggunakan langsung untuk pelayanan pasien. Oleh karena itu di RSCM kita sudah ada instalasi khusus, yaitu instalasi Laboratorium Penelitian Transaksional dan Kedokteran Presisi, sehingga tujuan-tujuan tersebut bisa terfasilitasi di instalasi tersebut. Dan yang kedua pembicaranya adalah Dr. Dicky. Dr. Dicky ini merupakan pilot project kita yang memang disupport oleh Kemenkes mengenai diabetes. Jadi dengan melihat presentasi Dr. Dicky, mudah-mudahan KSM-KSM lain bisa terinspirasi dan bisa mempunyai ide-ide yang lainnya yang kemudian bisa kita kembangkan ke depannya. Oleh karena itu kita mulai dengan Dr. Amol. Please Dr. Amol, the floor is yours. And you can use English here.
Thank you very much, Dr. Pino. And thank you for the organizers to giving the opportunity on behalf of Illumina to present here basics of next generation sequencing and how it is being used in clinical practice. Is it okay if I take out my mask or? Thank you. Can you put on my slides, please? Okay. Yeah, so as I mentioned, I'll be talking about next generation sequencing and what it means in terms of clinical applications. So for today, this is my agenda. I will talk briefly about Illumina, what we are. We realize that not many people know what Illumina is, and it is very, I think, important to understand that how we are working on newer technologies to bring the genomics into the clinic. So I'll speak briefly about Illumina. Then I will talk about genomics and what is NGS, and then going into the specific application in different therapeutic areas, such as oncology, rare diseases, infectious diseases, and so on. So this is our vision, is to improve the human health by unlocking the potential of a genome. And genome has a huge potential to impact the various aspects of human health, including, diagnosis, prognosis, as well as preventive medicine, and that's the principle which guides Illumina to develop solutions which could help us to really improve the human health across the globe. So we are based in San Diego, USA, founded in 1998, and last 20 years or so, Illumina has worked tirelessly to make genomic technology accessible to researchers, to the clinicians across the globe. And you will see that kind of a solutions Illumina has worked on, and also to make it accessible. It has really enabled the great research in different therapy areas. And now we see a lot of application of those research coming into the clinical space. So we have presence across the globe. In the region also we have a presence. We have our regional office in Singapore, and we are expanding our geographical footprint, now every day. And we really want to expand and have our presence in different parts of the world now. So we work with different therapeutic areas. So typically oncology, reproductive health, genetic diseases, microbiology. Also agriculture is kind of a big focus for us to improve the crop yield. We work for animal health as well, and molecular and the cell biology in the research space. So, but I will focus today more onto the human health in space of oncology, reproductive health, genetic diseases, and infectious diseases. We work with different stakeholders. We work with universities and academic research institutions to drive research, because still we feel there is a lot to uncover by genomics, and we heavily invest and committed to the research. And we work very closely with a lot of educational and research institutes across the globe. We work with pharmaceutical company to make sure that, when a drug is available in the market, we have the diagnostic test, which is really, complement the treatment decisions which physician could make. Also the genomic centers, biotech companies to enable them to come with different solutions, hospitals to make sure they have a capabilities to really test for the genetic diseases, and oncology and other spaces. Consumer genetics, now we see there are a lot of, the direct to consumer tests coming in. We help those companies to build solutions as well. And of course, government agency to educate them about value of genomics and how they should enable the use and adoption of NGS technologies within the healthcare. That's briefly about Illumina, and let's talk about genomics and what NGS is. So as you know, when we say about genomics, it is about understanding the structural, variations in human chromosome and the DNA. When we say genomics, it's really looking into at chromosomal and the DNA level, and at a single strand DNA level, looking at these base pairs of adenine, cytosine, thymine, and guanine. Various diseases, they have numerical abnormality in the chromosome, which means, there may be aneuploidies, uniploidies or trisomies, or there could be deletions of the chromosomal part. When you come to the DNA, also we see a lot of, the anomalies in the DNA in terms of deletions, some insertions, as well as translocations. And at a base pair level, we see these point mutations, single nucleotide polymorphisms, and that could lead to certain diseases. So when we say genomics, it encompasses all, right from the chromosome level till the single nucleotide polymorphisms which we see. So when we talk about DNA, there are two components of the DNA, coding DNA and non-coding DNA. So interestingly, the coding DNA just consists of 1% of our DNA. The rest of the DNA is non-coding DNA. So initially it was thought that non-coding DNA is kind of a junk DNA without any utility, but now our understanding of the non-coding DNA has increased a lot. So non-coding DNA, they have different regions which can promote, enhance, and silence certain genes. And also they could code from some specialized RNAs. Of course, for the coding genes is more about coding proteins. And in our bodily functions, proteins play a very important role. A lot of enzymes and other, the biological substances are produced in the body are kind of, coded by this coding section of the DNA and what we call them as a genes. In humans, we have nearly about 20,000 genes, but in some amphibians and other animals, we can see up to, the 10,000 and 100,000 genes as well. So the genes, they contain basic level information about, how our body functions. And activity of the genes is tightly controlled. And that's the reason most of us manage to stay healthy, the long part or throughout our life. So what happens in DNA? As I said, the single strand of DNA is made up of different base pair, ACTG. And we don't look similar. We may have a different skin color, eye color, hairs, and that is driven by the variations in DNA. So it's very natural to have the variation in the individual DNAs, and it is not harmful every time. It is needed for the diversity. And most of us, even though we have 20,000, the genes, we have a lot of polymorphism, which drives that differentiation between us. But what happens if we see that certain base pairs are getting, replaced, deleted, or added, that could lead to mutations. And that mutation could lead to the disease. And our focus area is to really understand those mutations, really characterize the disease, that what mutations are driving the certain diseases in different space. Okay, so when it's come to the sequencing, we hear a lot about sequencing. So what is sequencing? Sequencing is nothing but really reading these letters, ACTG, and ability to differentiate these letters. And there are different technologies which can do it. In early 1970s, Professor Sanger, he received Nobel Prize because he discovered the Sanger method, which is a capillary-based electrophoresis for really, sequence the DNA. And that has led to dramatic improvement in our understanding of genome. But the drawback of Sanger DNA was, if you look at it, can have just one read per capillary, and you can use 96 capillaries for one run. And in a day, you can produce data with 1.2 MB only. Now we live in an era of next generation sequencing, where we can have 4 MB to 20 billion, 4 million to 20 billion reads, per flow cell, which is a size of, the glass slide. And we can generate data up to 1,500 GB per day. So if you look at the advancement of the technology from 1970s until early 20s, has been very immense. Now we are in an era where we can sequence rapidly, sequence more. So just quickly about, what next generation sequencing is. In PCR-based Sanger sequencing, in Sanger sequencing, we use gel electrophoresis, and the current is applied, and there's a physical movement of, the DNA fragments. But what happens in NGS is more about, is fluorescent tag nucleotides, and we use the camera to really capture those images at a very high rate. And Based upon those images, the code is generated. For example, you can see here, green means G, and the blue means the different nucleotides. And depending on the color, you can really have that code generated very fast. So that's very simple on the basics of next generation sequencing, because today we just want to focus on what is the clinical application rather than going into the technical details about NGS. Okay, so one of the important things you will hear about the coverage and the reads, those who have a bit of, the technical discussion about genomics. So what read means is we have a reference sequence and we can sequence it once. So that is one read, right? But what happens sometimes, all the technologies are not 100% foolproof, and there might be some errors when we sequence the DNA. That's why it is very important to have the multiple reads. And when we do multiple reads, which are non-overlapping, you can see some of the nucleotides are getting sequenced more than once, but some are getting sequenced just one. So in this situation, initially we had the coverage for only 10 base pairs, but now adding 2 more read, we have increasing coverage up to 17 base pairs. So that's called a coverage. It is kind of an extent of DNA you are really trying to sequence. And the multiple reads, they give, so some base pairs are kind of read once, 7 base pairs are read twice, and 3 base pairs are just read, the 3 times. So on average, we can see that, this is 1.7. So that is kind of, the coverage for this. If we add multiple kind of, the reads, definitely the coverage increases up to, 2x, 10x, 100x. Depending upon what you want to do, currently for the whole genome sequencing, it is recommended to have nearly 30 to 50x. For a whole exome sequencing, probably 100x. So again, what you want to really do, that will determine the number of reads in the coverage in NGS. So I think that is too much of technical information right now for this session. So just these are some basic concepts of next generation sequencing. And let's dive into what are the clinical applications. But before that, just one point I have to make, that in early 2000, we did human genome projects, and that was a first attempt to really characterize the entire whole genome. That lasted for 13 years. The research lasted for 13 years and cost us $2.7 billion. In 2001, when these technologies became available commercially, the cost of whole genome sequencing was around $100 million for one whole genome. And now we are living in an era where we can really sequence DNA, whole genome, by 600 the US dollars. And Illumina is really committed to really bring down this cost, because it's good to have the technology, but if you don't have access to the technology for the researchers, for the clinician, the technology has no use. And one of the barrier is the cost. And we are constantly working. So Illumina managed to bring down the cost from 100 million US dollars in 2001 for whole genome sequencing to now nearly about $500, $600 for the whole genome sequencing. So that is a commitment of Illumina to really make genomics accessible to the broader healthcare professionals. And these are different solutions which we have depending upon the need, whether the labs need for their day-to-day use in hospital versus some bigger biotech technology, bigger labs. There are different kind of the solutions available which can optimize your workflows and the cost and efficiencies. Okay, now what are the applications? And let's go into the oncology, because oncology has been an area where it is driving the precision medicine, and partly because of the pharmaceutical industry is also working on the targeted therapies. And our understanding of the cancer has tremendously increased over the last 10, 20 years. And that has led to newer therapeutic development and really better patient outcomes. So I would like to give an example of lung cancer. And if you go back 20, 30 years, there wasn't many options available to treat lung cancer. But as our understanding of the lung cancer increased, the molecular understanding, you can see in the last 10, 20 years, there are different targeted therapies which are coming into the market, and the space is getting really crowded. And we now understood that lung cancer, non-small cell lung cancer, is driven by various mutations, EGFR, NTRK, ROS, ALK, and also there are pan-cancer biomarkers which play a very important role in lung cancer as well. So what it means, which means that you need to really understand what is driving the lung cancer in that particular patient, which mutation, and accordingly you can select the treatment for that particular mutation. So this is a precision medicine. So the days of trial and error has gone. these therapies are expensive. The physician has to make a right choice at the beginning. And to make that right choice, the physician need to understand that what is driving the cancer in that particular patient. And hence, the genomic testing for the cancer has become really important and really crucial, to make those decisions. It's not only lung cancer. Now we look at different cancers, thyroid, lung, ovarian, prostate, breast cancer. And now we realize that these cancers are kind of driven by different oncogenic drivers and mutations. We have certain mutations like BRCA, we have BRAF, NTRK. These mutations not only driving a single cancer, but they're driving multiple cancers. So now we understand a single cancer can have multiple genes, which could be oncogenic drivers, or we can have a single gene which can play an important role to driving cancers of different types. And hence, our understanding of what is driving that particular cancer need to be very well, and so that we can make a proper decision for the patient management. So when we started NGS long back, we thought one gene, one disease, or one gene, multiple disease. Now we see there's a lot of, the pan-cancer markers coming up. NTRK, tumor mutation burden, micro instability, and so on and so forth. And these pan-cancer biomarkers has a very important role in a treatment selection for different cancer sets. So what we can do? So this is again an example of lung cancer. So we can choose to do a very targeted mutation testing, like you do EGFR, that will take 5 slides of the tumor sample and turnaround will be 5 to 7 days. If that is negative, then probably you can use another technology, IHC FISH, to look for some more mutations. Or if you think there is a kind of, the MET exon skipping or there's a BRAF, then you have few number of more tests. So what happens if someone, a clinician managing lung cancer, has to go mutation by mutation? We can see the number of slides which are needed, which slides mean the tissue sample, and sometimes biopsies are very limited. We would not have ability to produce multiple slides for particular patients. And also the turnaround time. So that is really important, because once somebody is diagnosed with the cancer, the person is very anxious, and person cannot wait for 2 months to get a diagnosis. Oh, when can I start a treatment, whether treatment is right? And that's the reason having that quick turnaround and giving a precise answer is very important. So if you go ahead for the reflex testing one by one, what happens at the end is more about quantity not sufficient. So your lab will tell quantity not sufficient, and they cannot do anything more. And there are studies showing that the quantity not sufficient as a cause lead to nearly 25% times in management of the lung cancer, and about 20% in other cancers. And that is really a missed opportunity for the patients, because then we are not able to find a right solution for this particular patient. So now if you look across maybe in Indonesia or certain Southeast Asian countries in Asia, the standard of care for the cancer diagnosis is either a single gene testing, or we have hotspots panel, which means we have a panel of multiple genes, maybe 8, 10, 12, 15, depending upon what lab has to create. There are studies showing that if you use a single gene panel, or if you use a hotspots panel, there is a possibility to really miss a diagnosis in 60 to 80% cases. What it means that we are missing a diagnosis to treat that patient precisely. What comprehensive genomic profiling offers, it can really detect all the relevant mutations and also the pan-cancer biomarkers. So within a same sample size, you don't need multiple slides. Just with a small biopsy sample, you can have a clear picture about what is driving that particular cancer progression. So that is the value of the CGP. And this is not only from the technical front. There are different studies, and this is slide just summarizing, different studies, which has really shown that if we deploy CGP at front, we can really, kind of diagnose more of actionable mutation, ranging from till 90% cases, we will have some actionability driven by understanding of this mutation. So CGP plays a very important role in comprehensive genomic profiling to really, drive that actionability to a very high level. And when we look at the clinical data, so if you understand that, okay, we can do CGP, but what is next? And this is a study, showing in 249 cancer patients. And what they did is targeted therapies, matched therapies versus non-informed therapies, which means Few patients were offered CGP, and depending upon their report, the molecular tumor board decided that what is the matched therapy for those particular patients versus without CGP and non-matched treatments. And you can see in group where we had these matched therapies driven by the genetic understanding and discussion by the molecular tumor board, we see the PFS as well as OS, the progression-free survival, overall survival, and the disease stability is much more better than a group which received non-informed treatment. Non-informed means they didn't have any genetic information about making those decisions on therapies. So it's very high. Similarly, there are multiple studies in the community setting, in lung cancer patients, in adenocarcinoma patients, which shows that if you have a matched therapy informed by the genetic testing, then there is better outcome in terms of survival, progression-free survival, and overall, the patient outcomes in that particular group. So in nutshell, the application of the genomics, especially comprehensive genomic testing in oncology, will help you for the early detection of the cancer, comprehensive assessment, because you will have a full picture about what mutations are driving that particular cancer. It can serve as a monitoring as well. And most importantly, we can select and relevant novel treatment for those patients. So that's in brief application in oncology space. So let's move to a different segment now, which is non-invasive prenatal testing or the screening, which means, testing for unborn baby for potential genetic disorders in a non-invasive way. Fortunately, most of the births are normal. Nearly 97 births are normal, but we see 3 to 5% birth, they may not be normal. And what drives those birth defect or the genetic conditions are chromosomal abnormality, some prenatal exposures of toxins, cigarettes, alcohol, etc., single gene mutations. There are multifactorial regions as well, and our understanding is still increasing. We still don't understand why certain birth defects are driven by what pathology or etiology. So if you look at within these 3%, and these are the chromosomal abnormalities, and you might know the most common chromosomal abnormalities is Down syndrome, and looking at the chromosomal 21. So 21, 18, 13, they contribute almost 80% of the chromosomal abnormalities, and then we have others such as 45. Then sex chromosomes and other rare anomalies. So what we do typically in our, the pregnancy screening, there are different ways, and different countries have different practice depending on the resources. There would be NT-ultrasound, nuchal translucent ultrasound to pick up some of the changes in early fetus, or we do the blood screening, hormonal screening, and ultrasound. And there's a combination of these things, ultrasound, blood, and so on and so forth. So most of these approaches have detection rate ranging from 70 to 80%, in certain cases 90%. So there is a need to have a more specific and more sensitive solution to detect these chromosomal abnormalities, because false positive rate is also very high, nearly 5%. Then there are other methods which are invasive, such as chorionic villi sampling and amniocentesis, where you have to really put a needle near the fetus, which is quite dangerous. Though the sensitivity and the specificity is very high, the risk involved in this process is also very high. So what is the objective of this non-invasive prenatal screening technology or the testing technologies? Is to reduce the risk to the fetus. We don't want to put needle near the fetus, when a woman is pregnant. Reduce the false positive rates, and also the testing should be non-invasive and could be easily done in outpatient setting. And also it should enable the high detection rate. So what technology currently are available, which can enable us is using the cell-free DNA in the maternal blood. So we don't have to go to the amniotic fluid, neither we have to get the chorionic villi sampling to get a DNA. Now we can get DNA from mother's blood. So there is something called as, the cell-free DNA. And when a female is pregnant, we can see after 7 weeks of gestation, the level of this cell-free DNA really goes high into the blood, and it subsides very quickly after delivery. So we have that window to really draw the blood and analyze those cell-free DNA, which are originating from the cytotrophoblast, and they can inform about the genetic makeup of the child. So there are normal level of it, and once we do next generation analysis on this cell-free DNA, we can really see that normal the chromosome 21 versus, the trisomy, depending upon the amount of the cell-free DNA and analysis of the cell-free DNA in terms of number of chromosomes which they have. So in a sense, the message here is we have technology which can enable us to simply look into this by drawing a blood and not doing any kind of invasive procedures. So there are different methods available. We can do non-sequencing methods, but they have very limited, the ability to detect at a very high specificity rate. We have a targeted sequencing. You can only sequence for certain trisomies 21, 19, 18, that's it. Or we can have a whole genome sequencing targeting all the chromosome, wherein we can look for the chromosome abnormality across 46 chromosomes. So the technology can enable it, and that is called expanded, non-invasive prenatal testing, where not only for the common trisomy like 18, 21, and so on, we can look at all the chromosomes and can detect, some autosomal abnormalities as well. And when you look at, the screen positive rate, which is, if you include together all the trisomies, common trisomies 21, 18, 13, and sex chromosomal aneuploidies, the overall screen positive rate is around 1%, which means 1% of, the pregnant females would, have carrying either of these abnormalities. And that is very important for us to screen all the females. Intent is not to terminate the pregnancy, but prepare parents and the families for the arrival of the child, so they are well prepared in terms of the management of the child when the child is born. If we add whole genome onto it, and we can really look into rare autosomal aneuploidies across the chromosomes and genome-wide deletions, insertions, etc. And we can see really it adds another 5%, so 1.5%, because though we think it's rare, but it's almost like 0.5% females will be having some rare autosomal aneuploidies. So what is rare autosomal aneuploidies? These are happening because of the aneuploid fetus, or you can have the confined placental mosaicism and normal pregnancy. So definitely, if you want to test for the RIAs, there will be a false positive rate, and hence it need to be kind of confirmed with a confirmatory test, which could be an biopsy in that case. But it is serve as a very good screening method to even look at RIAs, which is rare autosomal aneuploidies. Right. So to my point, though we call them as a rare autosomal aneuploidies, they are not rare. They're almost present in 28% of the pregnancies. And hence testing for the rare autosomal aneuploidies also becomes very important. And when you look at the guidelines, now guidelines have understood the utility of these genetic technologies, and all the guidelines globally now recommending that each obstetrician should discuss with the female, irrespective of her risk, that this testing is available and should offer the testing. And all the international guidelines, AOCG, ISPD, ACMG, they recommend non-invasive prenatal testing for all the females. So that's about non-invasive testing. Let's switch the gear and come to the rare diseases, because today we are talking about a genomic application in the clinical space. And oncology, reproductive health are very important. So are the rare diseases. We think the rare diseases are rare, but they are actually not rare if you put them together. So there is no standard definition of the rare disease. Each country has their own disease. I'm not aware what is definition for the Indonesia, but in Malaysia, they had this definition last year is 1 in 2,000, the children. Similarly, in United States, if disease incidence is prevalence is lower than 200,000, it is considered as a rare disease. So different countries have different rare disease definitions. But what is important is 80% of these rare diseases are driven by the genetic component. So there is underlying genetic cause for the rare disease. And unfortunately, 50% of these rare diseases, they affect children. And definitely, it has huge impact on families and societies in general. What is important for rare disease, if you look at the diagnostic odyssey, which means family physician trying to find a diagnosis, it can last average up to 8 years, in some cases decades, and still you may not be able to find the answer that what is wrong with my child. Can lead to healthy life. But unfortunately, there is huge unawareness about rare disease among the practicing physicians. Of course, because if it is rare, it's not on your mind. And there's a huge unawareness about, the tests which are available to diagnose rare diseases. If you look at NICU admissions and PICU admissions, almost 1/3 of the admissions, they will, for critically sick babies, would have some kind of a genetic components. And it is estimated that 40% of the deaths could be attributed to some of the genetic component of the child. So if you look at these figures, even though it's rare, it has huge impact on in terms of the mortality and the morbidity for the pediatric population. And of course, because when we are into the healthcare system trying to find the answer for years and years and consulting different specialities for years and years, it adds up into a lot of cost. So in general, it's a huge cost for the healthcare system as well. So there are different solutions which are available by which you can try to diagnose a rare disease. You can have a single sequencing, or could do a targeted NGS, PCR, chromosome microarrays, or can do whole exome sequencing. But if you look at the number of mutations or type of genomic abnormalities which drive rare diseases, such as single nucleotide variations, indels, copy number variations, repeat expansion, structural variants, so on and so forth. These tests have certain limitation. Not all these tests could pick up everything, but whole genome sequencing has the ability to pick up all this variation, and that's where the value of the whole genome sequencing come in. Are we there yet to implement into the clinic? I don't have an answer, because every country, every healthcare system has their own priorities, own capabilities. But if you look at what whole genome sequencing has to offer for the rare disease patient, I think we have a comprehensive answer in terms of technology yet. And now it's our job to make sure that can we get this technology into the clinics to help the rare disease patients. So it has been proven in multiple studies that it improves diagnostic utility, it is faster, more efficient, and in long term, it is time and cost saving as well. Sorry. So what is the typical approach for the diagnosis of rare disease? So if you're suspecting a particular rare disease, either inborn or metabolism, autism, muscular dystrophy, then you have something in mind. You can do kind of a specific genetic test, targeted test. If test is positive, you got a diagnosis. If no, then you have to work out further. If the presentation, the phenotypic presentation of the patient is not very typical and it is not directing you to a particular disease, then what we typically have is targeted assays. So we do single gene, multiple genes, so on and so forth. But if we replace those different assays with whole genome sequencing, then we can get rid of all multiple testings and we can save a lot of time and cost for the patients as well. And there are multiple studies. So this study is into NICU and PICU, which talks about the clinical utility of the whole genome in pediatric population in sick children. And you can see it is very high, compared to when you don't use whole genome sequencing in those settings. Not only for the sick children in NICU and PICU, but also on the pediatric outpatient. If we deploy WGS for the diagnosis of the rare diseases, then you can see multiple clinical studies have shown, and as well as some analysis, that the clinical change management is much greater in that group rather than not having the whole genome sequencing. And that's the reason in last decade, the interest for whole genome sequencing in pediatrics has grown significantly. And you see the number of the publications which are coming up in last few years is huge. And there's another study looking at rapid whole genome, because when child is sick in NICU, you need a rapid turnaround time. And this study was looking at the rapid whole genome sequencing versus delayed whole genome sequencing. And if you look at the early arm, the clinical actionability, the change in management is much bigger than the arm which has a delayed kind of whole genome sequencing. So what this study tells us that whole genome sequencings definitely have a clinical utility. And if you're able to deploy into your NICU, PICU and able to get a rapid whole genome sequencing, you can do the chain management, which means you can really treat patients as per their disease and really in a very precise way early into their disease manifestation, which is really important for the children because they're already critically ill. So this is another trial, which is INSIGHT trial looking at whole genome sequencing in critically ill infants in NICU, PICU. And you can see again, the median age of diagnosis in WGS group is just 25 days versus 130 days in other group. And median time to diagnosis is just 14 days compared to 107 days when you don't use whole genome sequencing. This is another study in Sweden looking at the larger population outpatient basis. And in that population, we see the clinical diagnostic yield is almost 40% more in whole genome sequenced population rather than the targeted or other technologies which they use for diagnosis. Intellectual disability is again a concern because this is a very broad kind of clinical phenotype and driven by different genetic diseases. And in that, the chromosomal microarrays are kind of a standard of care. But if you compare with chromosomal microarrays, the WGS diagnostic yield is much higher, almost double than the CMS. So intellectual disability is again a very important kind of, the pediatric disease, which is driven by different genetic factors. It's a spectrum of disease, and whole genome sequencing has shown that you can really have a good diagnostic yield if you deploy appropriately. Right, so that's about rare disease. I know it's a lot to absorb. So this is my last section on infectious disease, and everybody knows about COVID. And Illumina was at the forefront when the COVID pandemic started. The first COVID variant was sequenced on Illumina platform. And then we rapidly expanded our capabilities and productions to make sure that we have sequencer available across the globe to enable governments, hospitals to have initially, the characterization of COVID discovery, then the detection, ramping up this kind of, the capabilities to detect efficiently. And then we moved on a surveillance. So right now, our focus is still on a surveillance to really, drive the surveillance about new upcoming strains, not only for the COVID, but different pathogens, which can pose a threat for the next pandemic. So what happened in the COVID? COVID really enabled understanding of the next generation sequencing, not only in the clinical community, but also with the administrators and ministries. So now we have instruments which are fairly available in different hospitals, in different centers. Now COVID is gradually going down. What we do with those instruments, right? So there are other health kind of, the burning questions in terms of, the infectious diseases, and they pose huge disease burden, in the population, and we are not thinking about them, how to tackle it. So at Illumina, what we are currently thinking is about, the respiratory diseases, and pneumonia is one of the most common respiratory disease. And if you look at the ICU admissions, pediatric and adult, the multi-drug resistance pneumonia or the drug-resistant pneumonia poses huge challenge in terms of the management. So what we are trying to do, if you look at the pneumonia is quite a prevalent, more than 3 million deaths each year happens because of pneumonia. And typical clinical approach is to send sample for, the cultural sensitivity and so on and so forth, microscopy, but that takes long time. And sometimes, patient may not, able to survive sometimes, and maybe can deteriorate because of, the inappropriate treatment. And again, another point is antimicrobial resistance for the pneumonia, which is increasing tremendously. And WHO has kind of declared that antimicrobial resistance is one of the top 10 public threats right now, and we have to really tackle it. And to address this issue, we have created this panel called Respiratory Pathogen Identification and Antimicrobial Panel, which really covers 281 pathogens, including bacteria, viruses, fungi. So in one test, you can really detect what is causing that pneumonia. And in addition to that, this panel can detect the 60 antibiotics, antiviral, and antitubercular drugs. So very effective way to really drive some research into the hospital to see what is driving that pneumonia, and what is a picture in terms of the antibiotic resistance. Another one is urinary tract infection caused by different pathogens, and typically these are self-limiting. But what we see that females especially, they have a recurrent urinary tract infections and infections because of the resistant strain, and that will add to a lot of mortality and morbidity. So address this problem as well, we have this urinary pathogen identification panel, by which with a single test, you can identify 174 pathogens and 18 classes of the drug to assess the antimicrobial resistance. So these are something coming in infectious disease space. There are various applications, and because the time which we have today, we cannot go into their application into the metabolic diseases, lifestyle diseases, and things, and so on and so forth. So typically, if you see, NGS has a huge application in different areas. The reproductive health, genetic diseases, oncology, metabolic diseases, driving a lot of research, drug discovery, and as well as the upcoming proteomic platform can complement the genomic testing as well. So in a sense, we are really living in an era where we can really exploit the potential of the NGS to bring those benefits to the clinics and to our patients, so that patients are treated in a very precise way and a precise manner. And how Illumina could help. So we could help to really, helping labs to build the capabilities by driving, supporting laboratories with implementations, by training, the staff to bring increase their capability to really, drive into the laboratories. In terms of the clinician engagement, we can work with hospitals, academics to drive evidence generation, implementing, this technologies into the hospital and see and show government that it can work in a local setting, driving clinical utility studies. Medical education, which is very important because not a lot of people understand NGS yet. So to raise awareness about NGS application, connecting with the global and local experts, and also having case studies discussion to show the real application in the real life, how it is helping patients. And of course, participating in hospital meetings and workshops. So that's where we think we can collaborate with you to really drive NGS forward and bring this solution into the clinics. So thank you very much. And if you have any questions, I'll be happy, or maybe after Dr. Dicky's presentation.
Yes, thank you, Dr. Amol. So now we will start our question and answer. You can sit in front together with me. So I think, can you show us the last slide, the number 69 slide? Because I asked specifically to Dr. Amol to show us what can Illumina do for RSCM and for us in Indonesia to implement this NGS. So if there's any question from the audience, if you can see, Dr. Amol really encourage us to ask them for help, to collaborate, to implement this next-gen sequencing in our hospital and other places in Indonesia. Is there any question, Doctor? Yes, please, Dr. Andri.
Thank you for your very nice presentation. I would just want to ask a little bit clarification, maybe my misunderstanding about some of your slide, mentioning that there are some high false positive, especially about the pre-birth test. Could you explain a little bit? Because if you mention high false positive, that it will be, quite not clear for me. So please explain a little bit. Thank you.
Some of the tests which we currently use, especially the anti-ultrasound and blood test for the screening purposes, it has been shown that it has a nearly 5% high positive rate, false positive rate. What does it mean is we diagnose the infant as having, trisomy, maybe 21, 18, or 19, but in reality, it's not, right? And that puts definitely a lot of stress on the parents, of course, because you tell someone that, there's a Down syndrome, the baby could potentially have a Down syndrome. And there's a 5% chance that it may not be because it's maybe false positive, right? So that puts a lot of, the pressure definitely on healthcare workers as well as on the families. And hence it is very important to have that specificity. So there are two aspects. So these tests are not diagnostics. These are screening tests. So when we talk about screening tests, which means, we need to have, it's good to have some false positive, because then you have to really confirm with the confirmatory test. If you have false negative, you're missing those patients because you're telling them, oh, you don't have a disease, but they're out of the system now, right? So the false positivity is very high, but it comes with some anxiety. And because these are the screening tests, you have to do follow-up tests for really diagnose that. And in those cases, the follow-up test would be really, doing an amniocentesis or maybe a coronary villi biopsy. If you pick up on a screening test that potentially a child might have a Down syndrome or some other trisomies or aneuploidies. So that's what the slide was on. But with newer, tests which are based upon a new generation sequencing platforms, right? They have a very high level of sensitivity, but at the same time, they have very high level of specificity also. So because most of the tests, when they're very sensitive, they give a lot of false positive results, right? Because there's a balance between the sensitivity and the specificity. So if you have really high sensitive test, then you'll get a lot of false positive, which you have to, again, kind of give confirmation by a diagnostic test, final test. But with next generation, we are reaching a point where we have sensitivity, specificity in 98, 99%. So that is the advantage of NGS over traditional screening methods, which we have right now.
Okay, maybe I would like to follow up Dr. Andri's question. So I know Illumina has helped a lot of centers in many countries to establish their genome sequencing center. So can you give us tips? What is the best thing to do first so we have a good foundation in genomic service? And also what are the pitfalls of genomic testing?
So it's just quite, interesting challenge which we have with NGS, because if you look at the application of the NGS, it's huge. You pick up any disease area and you see, okay, NGS can solve the problem. Now we're talking about disease like cardiovascular, diabetes, and other things, where now we understand that these diseases have genetic component, but the disease manifestation is because of interaction with the environment and lifestyle and so on and so forth. Some diseases are polygenic in nature, right? So we have polygenic risk scores now. But where do we start? Can we do everything? Answer probably no. So first thing is the building capability in the hospital. Having a lab which can cater to your clinical services. Now, what clinical services you want to really prioritize? And every country has a different priorities. In certain countries, they have oncology as a priorities. In certain countries, because of the declining birth rate, they want to focus on the reproductive health. In certain countries, the infectious diseases are the priorities. So once you have an instrument, a sequencer in your lab, then what capabilities you want to build first? So for example, when it comes to Illumina has certain ready solutions. For example, oncology, we have a ready solution like a comprehensive genomic profiling as a test, which you can just take and run. So you don't need to really, create your custom panel for that. For the reproductive health, we have, this basic trisomies, right? Basic NIPT, we have expanded NIPT. These are ready-made solutions from Illumina, which you can start running in your own hospital. So there is a lead time to develop some custom panel for your particular lab, right? So that's one part. So really looking at, low-hanging fruits and then implementing those. What is the most important thing is educating your clinicians about it. If your oncologists are not aware of what CGP is, how I can use it, where the test is available, and how do I interpret the result, and what I do after that, what is the clinical actionability, the adoption will not happen. So having lab, just one part of the solution. How we work with the clinical community to raise awareness with oncologists about CGP, with OBGY about this non-invasive prenatal testing. If you want to deploy something about pneumonia or maybe some other infectious disease, can we work with maybe respiratory physicians, and really collaborating with them to build that clinical solution, right? So we can help you, as I said, building your capability based upon your priorities in the lab. We can help you to drive education within the broader clinical community. We can connect you with the global experts who have a lot of expertise in terms of using this in real life, and they can guide it. Sometimes what happens, right, NGS, the report comes and you don't know how to interpret it, right? So finding right expert to guide through that is very important. That we can do because we have, our collaboration connections with experts around the globe, and they can help you to really decipher that report as well to make a clinical decisions. So these are a few ways. What is important for a hospital like you is having a roadmap. So let's start with this. Let's drive adoption and then move to next, maybe, the therapy area or the next level. We can do a lot basically for rare diseases. It's very complex because there are 7,000 rare diseases. Now, challenge with rare disease is not a diagnosis. We have a technology. There is no problem with the technology. Challenge is when a child come to a healthcare provider, either is primary care provider or pediatrician, they waste a lot of time and they keep consulting a lot of, the specialists because they are not getting diagnosis. So to get that patient to the lab, actually, we need to raise awareness about rare diseases. Phenotypic awareness. For example, if child comes with limb-girdle muscle weakness, muscular dystrophy, right? Can we develop a panel which is focusing on muscular dystrophy only? Can we have a panel focusing on inborn error of metabolism? If you are not able to implement whole genome sequencing right away, you can start with panel, and eventually, if you have multiple panels, then you say it doesn't make sense. Let's have a whole genome sequencing now. So education has to happen hand in hand, and different areas. Oncology, people want to know because a lot of things are happening in oncology. Rare disease, no one want to listen because no one care about rare disease. So each disease area
detect the UPD and the UPD. And can you explain more? How can it detect the UPD? Because I think UPD is about the methylation of the methylation, and then it can manifest such as the Prader-Willi syndrome or Angelman syndrome. What I know that from the whole genome sequencing, it can detect the deletion or duplication. And I want to ask too also, but can it also detect the translocation of the chromosome? And the second one, the question is, how big can we detect the deletion from the DNA that we can approach? Because sometimes in here we have disease such as thalassemia that it less than 10,000 megabase, 10,000 base pair. Can it detect less than that? And the third one, I have some read from the protocol for the Illumina that when you perform the extraction DNA and to do the whole genome sequencing, it costs a lot of labor and a lot of enzyme and region. Can you show us if we perform it in Indonesia? Can you show us whether we can reduce that but produce the same quality as the long protocol? Thank you.
Yeah, thank you for your questions. So regarding UPD, you're right. The utility of the diagnostics by NGS is not that high. It's into the 40 to 60% only. So UDP, the sensitivity and diagnostic yield is not that great when it's come to the NGS. And that's the reason in my slide, it was said that you have to do a confirmatory test, even though you patient may having the normal pregnancy, but it can pick up as a false positive, or it could be the false negative as well. So right now, for that particular thing, I think this technology is still evolving. But compared to other technology standard of care, I think the 40-50% is still pretty good, I would say. To diagnose this kind of a rare autosomal anomalies, because we are not really looking at rare autosomal anomalies right now. Our entire focus is on common trisomies, right? And the rare autosomal anomalies are not in the picture. And as we sequence more, understand more, probably in the future we can increase the diagnostic yield for the subsegments like UDP and so on and so forth. Your second question was around, sorry, I forgot your second.
Can it also detect the translocation?
Yes, it can detect translocation. So in terms of you talked about deletions as well. In terms of deletions, it can detect even 7 MB and less than that. 7 MB and less than 7 MB as well. Micro deletions also can be detected by the NGS. So there is another offering which is a micro deletions, right? Less than 7 MB. Currently, we are really contemplating, because if you go less than 7 MB, you'll pick up a lot of micro deletions, which are not clinically relevant. So can we develop a solution where we have micro deletions which are only clinically relevant? And these are only 4 or 5 micro deletions I'm talking about. But right now, technology can detect a lot of micro deletions, up to 2 base pairs as well. But what is the clinical significance of that, right? So there is no technological kind of, barrier to really look at translocations, small insertion deletions and things like that. That could be done. The question is, what is the clinical value of, detecting those small deletions and things like that? Lastly, about, cost and the reagent and efficiency, etc. So we have talked to my commercial colleague, because I don't know how much it costs. Honestly, I am a clinician. My job is to more of clinical value. And they'll be able to give you more clarity about, how you can really optimize your lab and drive efficiencies, One thing what I would suggest is, don't look at it in isolation. Instrument is an instrument. Sequencer can do a lot of things, can do oncology, can do RH, can do infectious disease. So as an organization, how you want to bring efficiency to use of that machine is important. And that will reduce cost for everyone.
Yeah, thank you.
So my name is Chiong, also from Illumina, from the commercial part, right? So to address the last part of the question, we always have a standard protocol that we recommend for customers to start with. And that's the protocol that we have optimized in-house. Now, I understand that challenges are always different in each country. Sometimes you have challenges with sample extraction, sample quality, right? But that's just a starting point, right? I think depending on the site, people can later optimize the protocol. So usually what happens is customers typically get trained on the standard protocol that we have for extraction. I mean, extraction kits are not from us, but we recommend what kits you use and the protocols follow. So that's usually the starting point because we have already optimized that protocol. But as you go along, as you know your samples better, you know your capabilities better, customers tend to optimize it for their own use based on the local conditions. And once you get there, right, you start to really optimize and really get it cheaper, so to speak, because it becomes much more efficient, less failures. So I think generally it's a starting point. It might look a bit challenging at the start, but as you get along, as you become more familiar and it gets optimized, usually it becomes a better, more efficient protocol for your local needs. Okay, thanks.
Ya, jadi Dr. Ilham, we have to start first and then we can try to make it optimal. Okay, is there any question from the audience? Is there any more? Yes, Dr. Dewi, please.
Thank you, Dr. Rina. I'm Dr. Dewi from Clinical Pathology Laboratory. Maybe my question is a bit basic, related to technical issue. Based on your experience, when we are doing the whole genome sequencing, there is possibility that unpredicted genetic variation may come up in our results. Is there any clue or tips that may ring the bell whether the genetic variation may significant in a rare condition or rare disease or rare clinical situation in the patient? As here in Indonesia, we have so many ethnic group that may also being more complex by mixed marriage. So yeah, do you have any experience that?
So that is a very good question, and that is a question we get a lot. What we do with variants of unknown significance. So because you do whole genome, you're really looking at the entire genome and you may find some mutations which are not documented. There is no clinical data on that and you don't know what is the clinical implication, right? But that should not stop us from implementing whole genome. Reason because these are, the variants of unknown significance today. More and more we sequence, maybe they will have significance tomorrow. They don't have significance today because we don't know anything about them because they have never been sequenced before, right? So some then would get classified as non-pathogenic because we see in the population and then we correlate with phenotypic findings and say it has no link. And then we know they are non-pathogenic. But to your point, in basically in South Asia, when there's consanguinity happening and things, and we might see a trend that particular variant is being found in a particular rare disease. And that may be very relevant to South Asia. In my previous experience with the Pompe disease, we found a variant in Pompe disease, which was reported only in Malaysia and was not reported anywhere in the world, right? So there are global databases where, we can submit, and look at what other people are finding. So we have to look at collectively with helping the entire healthcare community to understand, this very variants and genomes in a better way. Just because, I understand there are a lot of, the ethical issues around this, because if patient asks you about, what is this? This seems like, there is so many mutations I have and we have no answer. And then tell, I don't know what it is. And then patient is anxious about it. What do you mean you don't know what it is? Then why do you test me? So how do you handle that? So there are certain guidelines, especially in oncology. Now they say we should not be discussing about variants of unknown significance with the patients, So certain guidelines have few indicators how we should handle it. Clinical decisions should be just made on the well-identified variants which are pathogenic and not on variants of unknown significant. But it's a complex question, it's how do we communicate with the patient? How do we collect data? How do we know? But eventually it's a matter of time. As we sequence more and more, we'll get more clarity on those. But I don't think this problem will go away. There are so many genes and so many base pairs. So we will keep coming with variants of unknown significance here and there. So yeah, that's what.
Yeah, thank you, Dr. Dewi. And also that's why in our installation, KTRPM, we try to provide first the biobanking. So we will keep patient material and also bioregistry. So we will follow up this patient. So maybe it is now variants of unknown significance, but on the future, if we have a good bioregistry, then we can know the meaning in the future, not only for the diagnostic, but also for the prognostic probably, and also therapeutic response. And then second, we try to provide a genomic counselor, because that is very important. Before we analyze the genomic data, we have to consult the patient first and educate ourselves first. So it's something different. The clinician and also genomic counselor is something very different. But the key point is the board. I mean, the collection of experts is important at the beginning. That's why we start to establish that point.
So one of the advantage here is, when you sequence patient and entire sequence of the patients and the mutations, what happens sometimes, especially in rare diseases, right? There are panels of 10 genes, and you do the test and it comes negative, and you say, oh, it's negative, you don't have that disease, patient is happy, go home. And then 2 months down the line, there's a new paper comes up, says, oh, we identified 2 novel mutations. Now what do? You call patient again to test for that, or we have a data and we just look at data and see if those mutations are present in our patient, and then we know. So we don't have to call patients again, get a blood or a tissue to really look for this novel mutation. So there is benefit for that as well, because the way the research is growing, every other month, there are new mutations being reported, new novel mutations being reported. And once we have that data bank of our patients, we don't have to call patients back. We can just run through it and we know if those novel mutations are present in our population or not.
Yeah. It's very exciting. So maybe the last question, maybe in the Zoom. Yes.
Yeah, thank you, Doc. So we have a first question from Dr. Supriyanto. So Dr. Supriyanto asked whether is the working principle of microarray the same for all kinds of disease at the level of genomics, transcriptomics, proteomics, and metabolomics?
I believe each is different, right? So this is the broader principle would same, but there are technical differences between all those testings, and hence we have different sensitivities and specificities for different techniques. If everything is same for all those the technologies which we have, then probably it will give a similar result, right? So broad principle is looking at the genomic variation that is applied for all the technologies. But how we do it is a bit different for each of those. Transcriptomics, whole genomics is still NGS driven, I would say. Now proteomics also, kind of NGS driven. Chromosome microarrays are not NGS driven. So there are differences, definitely.
Maybe Dr. Amol, I would like to continue that question. For a diagnostic setting, would you prefer a microarray base or NGS with panel test?
So again, it depends upon, so NGS with panel is always going to be the costlier than microarrays, right? But is more efficient than microarray. So it's a balance between the resources which you have and what you want to achieve. In certain resource limited setting, they're still doing microarrays because microarray has been around for a long time. The cost is really low, easily implemented, give you quite good diagnosis on certain disease areas. But you lose a lot of, some percentage of patients which may not get diagnosed with that. NGS technologies are initially cost prohibitive, but you keep using and you have certain volumes and definitely cost can come down. What NGS can help is giving more diagnostic yield. There are multiple papers showing that compared to CMS, at least there is almost 50-60% more increment in terms of diagnostic yield. So it's a balance between your resources and how much diagnostic utility you want to have in your lab.
Is there any more question?
Yeah, so there is a last question, I think, Doc, from Dr. Sri Hartati. So this is more on the education part. So Dr. Hartati asked, who should explain the NGS test report to the patient? So for example, oncology test, can all doctors explain it to the patients?
So as a clinician, I'll answer, if I'm ordering a test, I should be able to at least have a conversation with the patient. Right? So accountability is with me as a clinician, because I cannot recommend a test and then say, I don't know about it. That's probably not a way we should practice medicine, right? So primary accountability is definitely with the treating physician to at least explain to the patient what's in the report. But we do understand these are very complex technologies, complex reports, and where the role of the molecular tumor boards comes in, where you have different experts, pathologists, you have oncologists, you have other colleagues who have experience. You can get, some experts from out of country, where we discuss those reports, those cases, and based upon those discussions, the solution could be provided. So though the primary accountability is with the clinicians, we need to think about how we build and support system to help clinicians to have that dialogue with the patients as well.
Okay, thank you. I think this is the last. The last question that we can have, Dr. Yani. So I will give back the floor to you for this session.
Thank you very much.
Thank you, Dr. Amol.
Give a round of applause to Dr. Amol and Dr. Dina. So before we head to the second session, which will be guided by Dr. Dina and also preceded by the presentation with Dr. Dicky, we're inviting you for a coffee break for 10 minutes. So the committee will provide you with snacks. And then after 10 minutes, we can start the second part of the session. Thank you. ladies and gentlemen, professors and doctors in RSCM network. Now we're moving to our second session. Here with us, so I'll be inviting again Dr. Dina to the floor as our moderator, as well as Dr. Dicky as a resource person. Before we begin our presentation, perhaps Dr. Dicky, we're inviting you to the floor to give the materials about the implementation of whole genome sequencing at the RSCM. To Dr. Dicky, the first source.
Okay, good morning. Good morning, everyone. The honorable guests, as well as Dr. Liz, Dr. Rizka, Pak Adrian Lembong, Pak Martin, Dr. Dina. So I was asked by Dr. Dina, my boss, to give a bit of sharing about the genomic study on early onset diabetes in Indonesia. So we will discuss later on. Maybe we haven't really heard the use of genomic for diabetes, but we try to convince you that the genomic testing in diabetes is actually very important, especially with the future treatment. Yes, sorry. So as mentioned by Bu Rizka before, that the BGSI is actually the integrated biomedical initiative trying to make a leap in terms of precision medicines. So we plan to integrate genomic capacity into health services. That's why it's now the location is at the Ekman, and we have 6 hubs from metabolic disease, cancer, infectious disease, genetic disorder, brain and neurodegenerative disease, as well as aging. So each hospital has its own specific disease target. And for RSCM, we have the metabolic disease, which will start with focusing on diabetes mellitus. So this is the overview of the target. It's shared by Bu Ines. From the short-term program, we want to establish a hospital-based genetic service. It depends on the hospital. For example, for Sulianti Saroso and for Persahabatan Hospital, it would be on tuberculosis. And for Darmais Hospital, it would be for cancer. And for RSCM, it would be for diabetes. And of course, in the future, we hope we can implement a new service and development of new method for genetic disease screening. So this is the building of Eichmann, and in this we have the Center for Transaksional Research and Precision Medicines, on which we now start the pilot project on diabetes. Actually, in the future, we hope we can also expand to other diseases as well. But for the start, we will plan to do the project on diabetes. So the reason why we chose diabetes is actually because of the huge burden. Currently, Indonesia, 1 out of 10 people, adult population, had diabetes. And if it is estimated, the number of people with diabetes is around 20 million. And the problem also translates into more than 86% were undiagnosed, so lacking in diagnosis. And those who were already been diagnosed and got treatment, only 30% getting their blood glucose under control. And importantly, about 25% is actually less than 45 years old. In contrary to previous belief that diabetes only suffered by people, old people, in Indonesia, about 1/4 actually less than 45 years old. And this also translates into high proportion of diabetes complications, which then lead to lower quality of life as well as increased direct medical costs. For complication, for example, about 60% of type 2 diabetes patients develop peripheral neuropathy. About 1/3 of the diabetes population develop eye disease. And diabetes retinopathy is actually one of the most leading causes of blindness in Indonesia. And if we move forward to cardiovascular disease, which is the number 1 in terms of cause of death, about 1/5 of Indonesian patients with diabetes had cardiovascular complications. The same goes for renal complications. We did our study in the past 2 years by doing an active screening for diabetes complication at the community level. And what we found is surprisingly very disturbing. About 40 to 50% of patients at the community level if we screen for renal complication, about 40 to 50% actually had variable degree of renal complications. So if this not treated well, so in the future it can go to dialysis and it also impact quality of life as well as cost. So this is the data from the BPJS showing that diabetes is associated with a huge impact on the direct medical costs. This is not to mention the indirect costs due to loss of work and so on. And it is because of the high complication. If you look into the graph, so majority because of the cardiovascular disease, followed by nephropathy, and then neuropathy, and then cerebrovascular disease, and then retinopathy. So this is a problem that we're currently facing at the secondary or tertiary care center. So the government is now trying to make a platform of the diabetes care model, starting from the promotions for those people at risk, and then perform a wide screening for the risk factor of diabetes, and then trying to also perform lifestyle interventions. So what we would like to do is actually we want to prevent the development diabetes start from the start. But of course, for those who has already had diabetes, had complication, had advanced complication, also need to be treated. And we also have this system of, I don't know the English word for pengampuan for the diabetes care in Indonesia, which is RSCM as the Rumah Sakit pengampu. We also now want to develop precision medicine as well, hopefully to improve the quality of care in terms of diabetes. So the use of the precision medicines can be used in terms of the insight generic. It can give insight in terms of the disease mechanism for specific for Indonesian populations, and then novel targets, also risk factors. But in terms of the clinical application, we can also use it for therapeutic optimization, for example, also disease risk, and also to predict which person will get the diabetes complication, so we can treat them earlier. We can develop molecular diagnostic, and also can be used to explain clinical heterogeneity among diabetes patients. So if you look into the genetic aspect of diabetes, of course, you have in simple way, we have the monogenic diabetes and we have the polygenic diabetes. More than 95% were actually at the polygenic. So we will discuss about the polygenic first, and then later on we will discuss about the monogenic diabetes. So this is the genetic variants that is associated with the pathophysiology of type 2 diabetes. It can range from the obesity, insulin secretion, insulin resistance, fasting blood glucose, and so on. This is a polygenic disease. In terms of the prediction for type 2 diabetes, unfortunately, usually the genetic variants on type 2 diabetes only give a small increase in terms of prediction from 5% to maybe 15%, not that much. In comparison to monogenic diabetes, if we have the genetic variant for certain gene, we can have a risk for more than 10 times. So up until now, for genetic prediction, usually we can still use the traditional risk factors, family history of diabetes, obesity, and so on. So in terms of in type 2 diabetes, there are also several studies trying to see which genetic variants were associated with increased risk for complications. Because this is very important, because if we can know earlier, then we can predict which patient will develop which complications, and we can perform an intensive intervention trying to prevent the development of complications. Could be from cardiovascular disease, retinopathy, and other complications as well. Aside from the prediction of complication, now we also in the era of the personalized medicine, there has now been characterized, there are 4 different phenotypes of type 2 diabetes. Maybe mostly we found people with mild obesity-related diabetes, as well as mild age-related diabetes. But on the other hand, we might also encounter people with diabetes who have a severe insulin resistance, and other phenotype would be with severe insulin deficient diabetes, which is more closely related with type 1 diabetes. And this actually could also affect the treatment choices that we would like to give to our patients. For those with insulin deficient, of course, we can give insulin. For those with insulin resistant, we can give drug that can lower the insulin resistance. So in clinical setting, this different phenotype would also urge to different treatment approach. And then the next would be on the pharmacogenomics. For example, there has been several studies, several genetic variants would be associated with a better treatment response or lower treatment response to metformin, as well as side effect, for example. The same goes for sulfonylurea and TZD. But the problem is the application of genomics in these settings actually is a bit difficult because this drug is actually quite cheap in comparison to the cost of performing the genetic measurements. But if we, in the future, we can lower down the price of the genomic, then it would make sense to provide at the clinical setting. But what about the newest drug? Let's say GLP-1 receptor analog. It is a new drug, then usually used for people, diabetes who had obesity, as well as who had cardiovascular disease. But it is very expensive. For 1 month in Indonesia, it could easily lead to the cost of 2 into 2.5 million rupiah a month. And if we talk about diabetes, it's not only about 6 or 1 year of cost. A different comparison to the cancer, for example, we talk about 6 month, 6 year horizon. In diabetes, if we diagnose the patient early, for example, 40 years old, we could expect the life expectancy could until like 70 years old. It means we need to give the drug for 30 years. So the cost actually in long term is very high. And actually not all people could respond the same to GLP-1 receptor analog. So maybe in the future, the genetic testing could give insight to the clinician as well as for the reimbursement system to select which patient will respond better to the treatment while also maintaining a lower cost in overall. So for type 2 diabetes, until now, there's no evidence base yet up until now. What we clinicians do is usually we combine the clinical characteristic of the patients. Different person characteristic associated with the different treatment of choice. But hopefully with the presence of the data on the genomics, we can also add a more detailed characteristic so we can select the patients better, which one would respond better to which drugs. So we can use it for the prevention as well as therapeutics. So actually in terms of the diabetes, the most evidence-based approach is actually now has been used in the diagnosis and treatment of monogenic diabetes. It's about 1 to 5% of all diabetic patients. It seems a little bit low number. If you see the numbers of diabetic population is about 20 million, it could easily about maybe around 200,000 people or 1 million people with monogenic diabetes. So it's still a huge problem. So what about the monogenic diabetes? It's actually usually diabetes that usually diagnosis in the young, less than 25, in some form might be less than 35 or less than 40 years old. And it caused by autosomal dominant transmissions and also lack of autoimmune antibody. So we'll discuss more about this monogenic diabetes. And the problem in Indonesia, we don't have the data on the numbers of monogenic diabetes because the kit to detect the monogenic diabetes is very expensive. We need to send abroad. It will cost easily around 1,000 euro for one patient. So if we have 1 million patients, you can predict how much is the cost to send abroad. So hopefully that's why we focus on the monogenic diabetes. Now I would like to move backward toward the huge number of people in Indonesia which has the diabetes less than 45 years old. It is 1 out of 4. And it is very important because it also will cause lower working productivity on those patients affected, also for their family. So it will also have a huge economic impact. And in terms of the complications, many studies have shown that those people who were diagnosed diabetes at the earlier stage would have the higher chance to develop chronic complications because the disease is usually more aggressive and they have a longer life expectancy to develop chronic diabetes complications. So when we, as a clinician, when we had the patient with the early onset diabetes, we have a diagnostic dilemma, whether this is a monogenic or whether this is polygenic. Up until now, we should just treat the patient as usual and see the response. If it did not give any good response, we can just switch to another treatment and so on. And the second one would be have faster beta cell decline in terms of the need of insulin, the higher chance to treatment failure, and then greater risk of complication as well as mortality. And that's why the genetic testing in this group of patients can be focused on, because this one has the more impact. So for example, for monogenic diabetes, if we can detect the mutation, for example, in HNF4A, for example, most patients usually treated with insulin. It's not only about the cost, but also about the quality of life of the patients itself. They need to inject the insulin 4 times daily and so on. But if we know the mutation, we can just switch the patient to sulfonylurea and the blood glucose can well control. The other one would be the glucose kinase mutations. This is the glucose sensing pathway. This patient doesn't need any medication. The patient can stop the medications, doesn't need any treatment, because it is only the matter of the glucose sensing and it is not associated with development of chronic complication. So we can easily just stop the treatment. So the genetic testing can help to differentiate the type, the therapeutic approach, and the prognostic of diabetic patients. But unfortunately, in Indonesia, we don't have diabetic genetic service available. We need to send our patients a blood sample abroad. So hopefully with the BGSI and the Diabetes Hub and under the CTRPM, we can provide this gap. So hopefully it can also improve diagnosis, but also improve risk stratification in terms of complications. Of course, we will combine the genomic data with the patient's clinical characteristic, trying to provide the personalized care to improve the quality of care. Hopefully to also improve the SDG by reducing the premature death for MCD, including diabetes. So this is actually what we are currently doing in Cipto Mangunkusumo. Before the BGSI, we actually have already started to do several studies evaluating the detailed characteristic of the patients and put the data into the registry as well as sample on the biobank. We haven't done the genomics for the past few years, but hopefully with the additional data of genomics, we have more detailed characterization of our patient and can provide personalized treatment to our patients. So this is the big design of the study. We will recruit the first year. We can recruit at least 1,000 participants for diabetes as well as another 1,000 for non-diabetes. We will screen for the presence of autoantibody to differentiate type 1 and other type of diabetes. And the most important thing actually, number 2, the risk of complication. We will perform head-to-toe examinations to evaluate cardiovascular complication, kidney, neurological, eye, liver, sexual, and other complication. So basically, although this is a diabetes project, actually we will have also a data on those non-diabetics, which patient actually can develop this complication. So the data itself can be used for other diseases as well. And this data will be combined. We will perform the whole genome sequencing. But of course, we need to have the low-hanging fruit. And we would like to focus on monogenic diabetes, of which the evidence is already quite clear. We want to create a gene kit, monogenic diabetes kit, so we don't need to send the sample of our patient abroad. And we plan also later on to develop complication risk gene kit, as well as providing personalized treatment in terms of exercise medicine, in terms of nutrigenomic, as well as pharmacogenomics. So this one is the simple graph for monogenic diabetes. We also have collaboration with the pediatric endocrinology as well. So if we know one of the mutation, for example, we can have different treatment for each patient. So the patient would get treated, and you see here not all patients usually need insulin. And usually, if most doctor, if they meet a patient less than 30 years old, they will suspect they have a type 1 and then just start the insulin. So actually, this kit would help the clinicians. So in clinical setting, it can be applied by later on, we have the MODI probability calculator. If the score is high, so we can refer the patients, could be from RSCM, could be from the vertical hospital in Indonesia, to send the blood to RSCM, and we can do the genetic testing and we can provide the data. So the doctor in charge for the patient can then select the treatment which is more appropriate to the patient based on the result of the monogenic testing. This is the test usually we send abroad. It costs about 1,000 euro one test. And this is the plan for the diabetes hub. We first want to start with the monogenic diabetes and will expand to complication LVSS therapeutic genomics, but also it can also be expanded to other diseases as well. Maybe later we can discuss with Dina as well. And as you see, if you walk through this door, we already start the pilot project start today. Today we start piloting project. We invite patients, normal healthy control to come. We perform questionnaire, physical exam, imaging, and also blood sampling. And we perform a quite complete examination. This is the eye ophthalmologist performing the eye examinations. We have the urologist performing examination in the urology aspect. We have the neurology department. We have the cardiology. And of course, this will not be possible without the support of other departments in RSCM. We are very happy because almost all the department in RSCM supported this program despite only a very short notice. We have a support from cardiology, neurology, gastroenterology. So despite it's only the diabetes hub in the name, but actually in the examination is actually quite complete. So if still there any other department would like to join to add for some examination, clinical examinations, you are most welcome to join the project, because it will not only assess diabetes patient, but also healthy control. So we will have a lot of data generated from this project. So we will start with RSCM, and we will then expand to Jakarta and then to the other hospital. Last week we had a discussion with the local health authorities in Jakarta, and they are really interested to also to join the genomic project itself. So hopefully we can have more subjects from the Jakarta and surroundings. Okay, in summary, precision medicine for diabetes in Indonesia is still currently on its earliest phase, and RSCM will start with early onset diabetes because high proportion of monogenic diabetes, more progressive, and have a higher burden into the financial system. So, of course, I'd like to acknowledgement Dr. Liz, also Dr. Dina as the team. I'm an endocrinologist, so that the data analysis will be done, for example, by Mentari, who is expert in bioinformatics, biobanking, by Harvey. There's also Nabila, Sana, Selfie, May, and also Vidya as our genetic counselor. In terms of clinician, we have adult and pediatric endocrinology, as well as experts from other departments as well. I think that's all. Thank you for your kind attention.
Thank you, Dr. Dicky. I think that was a very good presentation and well delivered by Dr. Dicky. So is there any question from the floor? Yes.
Thank you very much, Dr. Dicky. Mungkin saya pakai bahasa Indonesia.
Boleh,
boleh.
silakan.
Ini nanti dalam pengumpulan informasi dan sampelnya kan seperti tadi bilang, Dr. Dicky udah bilang akan mungkin kerjasama dengan pihak lain karena mencari sampelnya nggak akan mudah karena pengen tipe tertentu ya. Kira-kira apa nanti ada rencana untuk mulai dibuka kerjasama dengan rumah sakit lain? Apakah ini tadi dibilang kan mau fokus di Jakarta dulu? Mungkin bisa sedikit dijelasin rencana pelaksanaan programnya untuk bisa mengumpulkan sampelnya seperti apa?
Iya, makasih Pak Adrian. Ya memang monogenik diabetes ini agak susah memang carinya karena kita nggak punya datanya. Nah, makanya kita akan fokus di yang mulai dari masuknya dari early onset diabetes supaya dapat tidak hanya monogenik tapi sebenarnya juga yang more progressive disease tadi yang pada early onset. Jadi kita mulai dari RSCM, kita sudah identifikasi pasien-pasien yang onset diabetesnya usia muda. Kemudian kita expand juga. Kita sudah kolaborasi dengan dari AHSUI, Rumah Sakit Pendidikan UI, sudah pernah bertemu juga dengan para pimpinannya untuk membantu sebenarnya proses-proses termasuk si referral dari pasien. Minggu lalu yang tadi saya ceritakan, kita pernah audiensi dengan DPR sebenarnya, DPR DKI, Pak Adrian. Sebenarnya terkait dengan proyek yang lain, penelitian yang lain terkait peningkatan kualitas layanan primer, tapi salah satu yang mereka encourage adalah mereka tertarik untuk terlibat dalam penelitian genomik. Jadi kita akan juga gandeng layanan primer, puskesmas di DKI, kalau mereka ketemu dengan DM usia muda, mereka bisa refreshing untuk pemeriksaan. Nah setelah itu kita harapkan bisa expand juga ke rumah sakit di luar AHSUI dan di rumah sakit vertikal Kemenkes. Yang mungkin yang perlu diperhatikanlah terkait dengan pengumpulan sampelnya, karena pemeriksaan yang kita kerjakan di RSCM memang sangat lengkap, Pak Adrian. Mungkin satu pasien bisa berapa dokter Rina, 3-4 jam ya, karena pemeriksaannya lengkap. Karena kita harapkan bukan cuma untuk diabetes sebenarnya, dari yang normal tadi kan bisa ketemu pas penyakit yang lain, nanti bisa digunakan juga sebenarnya untuk penyakit-penyakit yang lain, tidak terbatas di diabetes. Nah kalau ini mau direplikasi di rumah sakit lain, tentu saja nanti kita harus diskusi dengan rumah sakit vertikal yang terlibat, pemeriksaan apa yang minimal perlu dikerjakan. Jadi mereka bisa kerjakan pemeriksaannya dengan standar yang sama, nanti yang dikirimkan ke RSCM tinggal sampel darahnya yang akan kita proses biobanking dengan sistem registry yang juga nanti akan integrated, nanti masuk ke dalam ke BGSI. Nah, mungkin yang challenging terkait kalau rumah sakit lain yang terlibat harus bisa melakukan pemeriksaan yang standarnya kurang lebih sama, dan mungkin tidak perlu se-ekstensif di yang dikerjakan di RSCM, tapi sesuai dengan kemampuan SDM sama resources yang ada di masing-masing rumah sakit. Itu harapannya sejalan juga dengan yang pelayanan Pak Adrian, yang diabetes center ada RSCM, ada pengampuan 14 rumah sakit vertikal itu bisa masuk, jadi link nanti antara pelayanan dengan proyek yang genomik ini.
Saya rasa terus terang kalau pengalaman saya dalam program seperti ini, sebaiknya memang pemeriksaan tetap dilakukan di sini. Jadi saya rasa kalau Dr. Dicky udah ada pembicaraan dengan Dinkes di DKI, mestinya proses rekrutmennya itu relatively manageable, sehingga memang kita bisa memastikan kualitas dari datanya itu benar-benar bagus. Jadi kadang-kadang kalau kita kas terlalu besar, mau dapat sampel banyak, kerjasama sama banyak rumah sakit, ternyata nanti mulai dari pemeriksaan-pemeriksaan yang mau dilakukan, ternyata datanya nggak 100% comparable. Jadi memang kalau mungkin untuk awalnya, untuk untuk pembangunan database pertamanya, kalau bisa kerjasama dengan Dinkes di sini, menurut saya proses rekrutmennya sih udah cukup bagus ya, sehingga kita dapat pool data yang kualitasnya baik karena memang pemeriksaan dilakukan di sini. Jadi saya rasa saya setuju banget, saya support sekali kalau memang kita bisa kerjasama dengan Dinkes, itu akan sangat membantu. Terima kasih banyak Pak.
Iya, terima kasih Pak Adrian. Memang kita juga pengen dapat data dari etnis yang lain ya, itu makanya perlu terlibat dari rumah sakit yang seluruh Indonesia sesuai dengan arahan Pak Menkes juga. Cuma challenging-nya tadi, kualitas data klinis yang di-generate itu sebaiknya sama, karena kalau kita punya data genomik tapi data klinisnya karakteristiknya kurang lengkap atau tidak sama standarnya, nanti akan sulit di bagian analisis nantinya ke depannya. Terima kasih Adrian.
Terima kasih Pak Adrian. Jadi memang kuncinya di sini penelitian yang dilakukan oleh Dr. Dicky ini memang kita pilot project. Jadi memang kita berusaha sekali seideal mungkin. Tapi mungkin Prof dan dokter-dokter lain bisa melihat bahwa ini semua tuh datangnya masalahnya dari pasien ya, Dr. Dicky ya. Dr. Dicky melihat bahwa banyak permasalahan di pasien lalu dibawa ke level penelitian, dan Dr. Dicky memang pada dasarnya sudah banyak penelitian klinis yang sudah beliau lakukan sebelumnya. Genomik ini adalah pelengkap dan juga menjadi hal yang exciting untuk kedepannya, karena selain dari masalah genomik, Dr. Dicky juga melakukan biobanking dan bioregistry tadi, dua hal yang memang harus kita dekatkan. Jadi data genomik ini tidak ada artinya dibanding kalau kita tidak punya data klinis. Jadi mungkin dari KSM atau dari teman-teman yang lain ada pertanyaan. Di sini sih kita pengen banget menginspirasi teman-teman di KSM untuk bukan memulai sebenarnya, tapi melengkapi apa yang sudah teman-teman lakukan di KSM. Misalnya di KSM kan pasti, misalnya kita punya tumor board. Nah, habis ini mungkin tumor board ini yang akan berkolaborasi, yang kita lengkapi dengan data genomik misalnya. Mungkin ada pertanyaan dari Zoom, mungkin sudah ada dokter. Ya, silakan Dr. Yan.
Ya, Dok. Ada pertanyaan dok dari Dr. Ikhwanuliman Putra. Jadi yang pertama, apakah dalam memulai WGS pada diabetes akan langsung mapping reference genom individu sehat yang mewakili banyak etnik, jadi 1000 sampel kontrol studi misalnya, menyerupai 1000 genom project sehingga kedepannya bisa dilanjutkan SNP array atau imputasi yang mereduksi biaya. Ini teknis sekali pertanyaannya dok. Yang kedua, apakah dalam roadmap-nya berkolaborasi dengan negara-negara ASEAN sebagaimana halnya reference dari project lain 1 million European Genome sehingga bisa jadi leader di kawasan ASEAN. Terima kasih atas pertanyaan.
Ya, Dr. Dicky mungkin mau menjawab yang pertama dulu, Dok.
Iya, jadi memang harapannya kita kan ada sampling yang normal juga sebenarnya untuk reference sebenarnya. Kita targetnya 1000. Tadi Bu Rizka menyampaikan ada 10.000 sebenarnya. Jadi 1000 itu targetnya kita dapatkan sebenarnya tahun pertama Dr. Ladis ya. Cuma memang agak mundur nih. Tahun ini jadi kita harapkan 100, nanti tahun depan bisa mencapai 1000 dan harapannya itu akan berlangsung terus, tidak berhenti pada 1000 dan akan berlangsung terus. Jadi kita dapat punya biobank. Jadi kita akan dapat reference dari populasi di Indonesia dengan lebih baik. Dan makanya nih pertama kita coba Jakarta dulu supaya sistemnya jalan. Jakarta kan juga multi etnis juga ya, tapi tetap kita perlu expand ke level nasional juga supaya kita dapat perwakilan dari seluruh sebagian besar etnis yang ada di Indonesia. Ini tuh ya.
Ya, mungkin melengkapi, jadi Dr. Iwan di sini di mana BGSI atau inisiatif yang memang berusaha untuk meningkatkan pelayanan genomik di Indonesia, kemudian memiliki data pasien sehat sampai 10.000, karena kita memang di Indonesia belum ada sama sekali dan kita di RSCM berusaha agar pasien sehat ini juga memenuhi kriteria pasien sehat sebaik mungkin, karena memang definisi pasien sehat pasti berbeda. Mungkin kalau pasien DM, pasien sehatnya seperti apa dibandingkan misalnya pasien penyakit yang lainnya. Oleh karena itu, data kembali kita berusaha untuk menjaga kualitas data klinis yang paling baik dan benar. Emang kita perlu reference genom dan pasien sehat ini adalah pasien yang kita akan jadikan reference genom. Tentang roadmap, pastinya kita mau pergi ke nasional dan juga mudah-mudahan bisa pergi internasional. Mungkin di sini saya mau I want to bring Dr. To discussion because as you can see, you already see how Dr. Dicky planned his study. Do you have anything to add? And how do we collaborate in the international level, at least in ASEAN countries and or Asia where you work with Illumina right now?
Yeah, so I also had a couple of questions for you on the presentation, right? So as I mentioned that, monogenic versus polygenic, and polygenic is a bit complex than, but even in monogenic, because it's a metabolic disorder and the genetics has a component, but again, the disease progression, the treatment efficacy would be again driven by the lifestyle also, the diet and exercise and things like that, right? So to really bring the precision medicine into the clinics and really offer these as a kind of, let's say screening test for the patient and match to appropriate therapy, you need to prove the clinical actionability, right? That this test will help us to determine it. So one of the challenges which I see plan to get those other elements, the diet and other things into the study to generate an evidence showing that with this genetic testing and this intervention, there's a better outcome. And then government is willing to subsidize then, right? That because that is ultimate goal. We should have to have some subsidies on the testing. So have you thought about, those elements in this study or, the registry which you are building for diabetes? And then I'll come back to your question.
Yeah, actually, we have already tried to plan to also incorporate the lifestyle genomic aspect on the lifestyle in terms of nutrigenomics as well as exercise genomics. Actually, we have also some private vendor who actually can provide this nutrigenomic, and actually also quite now actually it's increasingly being used by clinicians to direct the program in terms of the dietary modification as well as type of exercise. But usually it's only covered for those who have a lot of money, right? Because it's still quite expensive. What we would like to do actually in the next maybe 2 or 3 years, already have the plan. We have already had discussion with the clinical nutrition and also from the sport medicine as well. We also plan to develop a panel gene as well, based on their experience or from the reference, also to provide the personalized approach And then, of course, because it's still very expensive, of course, we need to see whether the genomic-directed approach would give a superior metabolic control in compared to our standard of care. So hopefully, maybe after the monogenic diabetes, we can also do the clinical trial using the developed nutrigenomics or exercise genomic kit to direct the patient in terms of lifestyle modifications in comparison to the standard of care. If we can see a huge difference, so maybe we can also calculate the cost, right? The cost for the genetic testing in comparison, the cost that can be saved by reducing the A1C maybe 1 or 2% in the long terms. So I think the issue in the clinical application usually on the cost itself. But for diabetes, actually, we need to see the horizons longer because it's not just 6 months or 6 years of treatment. It will give a benefit in terms of maybe 20 to 30 years in the future. And the genomic testing only can need to be done only once, right? Just you can just then apply the lifestyle, even the pharmacogenomics maybe later on. Yeah.
So far, our end, we are also looking at some metabolic disorders and pharmacogenomics, polygenic risk scores, and things like that. We are collaborating with different researchers across globe who are interested to look into this space as well, because now we understand that metabolic disorders, they do have a genetic component, but we're still trying to identify what impact and how much impact the genetic component has on the patient outcomes, because these are multifactorial diseases, right? It's not like oncology or the cancer where you have mutation and you know exactly the cancer is there, right? So yes, of course. So this is, to your point, this is a very early phase right now because we are learning a lot in terms of novel genes, what is the impact of the genes, and so on and so forth. So from our end, what we can do, sharing learnings about what's happening globally, how people are looking at any collaborative opportunities and things. But one point, if your broader goal is a metabolic disorders, then a lot of work has been done in the cardiac space. Cardiomyopathies, and so now we know the cardiomyopathies have a genetic origin, and you can risk stratify patients and the management of cardiomyopathy. So I'm not sure whether in future, if you want to look at the cardiac space as well in terms of the precision medicine approach within Indonesia. I don't know the prevalence of the cardiomyopathies right now in Indonesia things, but that is one of the evolving field which I see. The another comment about for your approach. Maybe considering some retrospective study matched with the therapies. So if patients on treatment, and you can see if they're on DPP-4, SGLT2 inhibitors, or GLP-1, and matching their demographics and lifestyle, and then looking at the genome, and then making some inference, certain genes are making any difference in the outcome in terms of diabetes control. So that would be again one, because then you don't have to wait prospectively, but you can really look at the retrospective data, and you can kind of case control match and have that initial insights about the impact of the genome. So that's another way to look at it.
Yeah, I think that the design is already a longitudinal study, so I think we can incorporate the different of treatment. So I would like to raise a problem, is actually Pak Adrian as well, because here in Indonesia usually we not really involved in the clinical trial from the newer drug in diabetes. We only become the market of these very expensive drugs. I think we need to also urge that the government will also need to be involved in the clinical trial as well, because then we have the genomic data, we have the data of efficacy as well, because it might differ as well. Because for example, for GLP-1, we see a more better response in most of our patients compared with the lower dose, for example, compared to those in Caucasian and so on. But I think the issue is not only about bringing the data from hospital base, but also to be involved in the international clinical trials on diabetes drugs. Otherwise, we can only be the market of those drugs actually.
Yeah, I agree very much. By having this infrastructure, will put us in the map of clinical trial research. Yes. Okay, is there any other question in the Zoom?
Yeah, there are some questions, Doc. So the next question, selamat pagi. Tadi sudah sudah di-briefkan sama dokter oleh dokter terkait pengambilan data awal. Nah, kira-kira berapa lama kohort yang akan dilakukan dan kapan atau seberapa lama interval waktu dilakukan untuk pemeriksaan ulang pada subjek penelitian?
Iya, yang sekarang kita lakukan itu kita rencana 2 tahun ya, Dokter Rina ya. Tapi harapannya sih bisa berlangsung terus ya. Tentu saja akan tergantung banyak hal, termasuk support funding dan sebagainya. Untuk pemeriksaan yang kita kerjakan nanti interval 1 tahun kita akan ulang lagi untuk melihat ada progresi dari komplikasinya, perbaikan metabolik dan lain sebagainya. Tapi memang kalau kita bicara komplikasi diabetes memang seharusnya lebih lama ya. Kalau UKBDS tadi bisa 5, 15, 20 tahun bahkan. Jadi kalau itu bisa di-sustain dalam jangka panjang, maka data yang di-generate akan jauh lebih bermanfaat dibandingkan cuma 2 tahun. Gitu.
Ya.
Tapi sebenarnya kita aim untuk mulai dari 2 tahun dulu, tapi harapannya bisa terus berlangsung.
Karena kita juga punya komponen KSM ya, masing-masing departemen. Contohnya mata, nanti mata ada perhitungan kapan akan periksa fundus matanya. Jadi itu pentingnya tadi biobanking dan bioregistry. Kita keep data pasien ini sehingga kita nanti bisa nge-refer kembali ke genomik datanya. Jadi ini akan jadi data yang sangat kaya. Ada lagi pertanyaan, Dr. Rian?
Iya dok, ini terakhir dok dari Dr. Wina Sinaga. Jadi melanjutkan terkait dengan kolaborasi. Ini sepertinya dari KSM Gizi ya. Jadi pertanyaannya, apakah data asupan nutrisi dan status gizi juga diambil dok? Sekiranya Departemen Ilmu Gizi RSCM FKUI bisa ikut ambil bagian. Terima kasih. Dalam research.
Iya, ya setahu saya ada ya di dalam registernya kita ada asupan datanya, tapi kita akan most welcome kalau memang dari gizi klinik akan gabung. Tentu saja evaluasi gizinya akan lebih spesifik lagi ya dan bisa memberikan banyak data untuk proyek besarnya sebenarnya. Harapannya ke depannya sebenarnya proyek ini kan nanti incorporated dalam layanan sehari-hari sebenarnya. Dalam arti pemeriksaan komplikasi diabetes ini kan sebenarnya berdasarkan panduan klinis semuanya udah ada gitu, wajib dikerjakan. Cuma dalam pelaksanaannya seringkali banyak miss nggak dikerjakan. Nanti harapannya ke depannya ini berjalan, semua pasien diabetes diperiksa komplikasi kroniknya, kita punya data genomiknya, jadi itu akan incorporated dalam layanan unggulan yang ada di RSCM. Terima kasih.
Oke, nggak ada pertanyaan lagi dari audiens, dari forum ada pertanyaan? Bila tidak mungkin kita tutup sesi siang ini dan mungkin saya mau sedikit membuat kesimpulan pada pertemuan siang hari ini. Mungkin teman-teman dari KSM atau teman-teman yang di Zoom juga sudah melihat penelitian Dr. Dicky ini memang ekstensif, tapi untuk genomik kita bisa approach 2 hal, bisa ekstensif seperti Dr. Dicky, sehingga kita bisa melakukan penelitian yang prospektif dan diikuti, tapi kita juga bisa mulai dengan sesuatu yang simple. Jadi misalnya sudah ada penelitian di luar negeri atau sudah ada pelayanan di luar negeri menggunakan genomik, itu tetap saja kita bisa mulai duluan, setidaknya kita bisa memberikan pelayanan yang terbaik untuk pasien. Dari apapun approach-nya, saya sangat amat mengencourage teman-teman yang ada di KSM untuk memulai, dan kita di instalasi Laboratorium Penelitian Transaksional dan Kedokteran Presisi siap untuk membantu, jadi silakan kontak ke kita. Dengan demikian mungkin saya tutup acara siang ini. Terima kasih banyak kepada para peserta yang sudah memperhatikan baik di ruang auditorium maupun di YouTube, kanal YouTube ataupun di Zoom. Wassalamualaikum warahmatullahi wabarakatuh.